بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. السلام عليكم جميعا. Welcome everyone in this PM&R in Focus series, the first one in its type in Saudi Arabia, and we are really excited and honored to have this this high number of registration. Today we'll start our first lecture. And before we start this series of lectures, we would like to have a brief introduction from Dr. Muhammad Al-Atawi. He is the chairperson in King Fahad Medical City for the PM&R department. Please, Dr. Muhammad, the floor is yours.
يعطيك العافية دكتور محمد. Thank you. طيب بسم الله الرحمن الرحيم. It's my great pleasure to welcome you all to the PM&R in Focus Tip of Daily Practice. This initiative is organized by the Department of Physical Medicine and Rehabilitation at King Fahad Medical City, and this initiative was launched through our physiatrists to foster continuous learning and to share practical knowledge among colleagues in PM&R in different areas. Also, I would like to thank all the speakers who contributed their expertise across the different rehabilitation domain in the course, including stroke, spinal cord injury, MSK, pediatric rehab, brain injury, and neurorehabilitation. Also, I would like to thank organizer Dr. Muhammad Jamil and his team, as well our colleague in Sultan bin Abdulaziz Humanitarian City for their contribution in the course. We hope this session will enrich your daily practice and enhance the quality of care provided to our patient in PM&R practice. Welcome all, and we wish you a fruitful and beneficial experience in the course. Dr. Muhammad Jamil, the mic is yours.
Thank you so much, Dr. Muhammad, for this introduction. Now let me introduce our speaker for today, Dr. Ahmad Qureshi. He is a subspecialty consultant in physical medicine and rehabilitation. He just left King Fahad Medical City, and he was the stroke rehab program director in King Fahad City for around 15 years. He received his subspecialty training in neurorehabilitation and interventional rehabilitation from USA. He has also more than 40 publications in the field of rehabilitation and has presented at various national and international platforms. He also initiated the baclofen program in King Fahad Medical City, and he was and always he's a great mentor for the residents and his colleagues, and take them to the next step. Thank you so much, Dr. Ahmed, for your previous effort, and the floor is yours. Please go ahead.
Assalamu alaikum wa rahmatullah. You can hear me?
Yes, Dr. Ahmed, we can hear you.
Hey, yeah, good to hear familiar voices, and thank you very much for the invitation as well. I just want to make sure that the slide is visible.
Yes, it's visible.
All right. All right. So, I'm going to be talking about rehab of stroke survivors from a practical experience-based perspective. And I understand that the whole idea is probably not to go extensively into the theoretical aspects, and also not to go into the evidence-based. And part of the evidence is also experience as well. So this is more of a experience-based perspective from my angle. So there's one thing which I read, and which talks about you have either excellent quality care or the patient suffers. I think as time moved on, by virtue of experience, I believe that this is something that is truly reflective in our clinical practice. And I'm pretty sure if any one of us had a chance to be admitted or being with somebody who has been admitted, in terms of loved one, we may have come across a situation where we may have felt that many of the things are excellent, but some of the things which may be important for us, if they're not going through, that carries a greater negative impact on our experiences. So hospital systems are complex. Rehabilitation is most integrated interdisciplinary branch of healthcare, and humans are different. Okay, I see a message that the sound is not well. Is it any better now? Okay, so let me know if there's a, okay, all right. So since humans are different and each one is different as well, and so are we, so it is very difficult to have such an integrated form of care which could be optimal in one health setting. So what I would like to say is that there are three levels where the factors in a rehabilitation setting can be divided. One could be institutional factors, the other one is operational factors, and then we can talk about the disease group specific factors such as stroke. So the reason I'm mentioning that is because I understand that today is the first session, so I want to set the tone. I would probably go on the stroke rehabilitation practical perspective later on, but I would like to touch base a little bit on the number one and number two. So, we can have an understanding that how clinical management is impacted by institutional factors and operational factors, be it stroke, spinal cord injury, or brain injury. So institutional factors is, in my opinion, what you and your patients need in healthcare setting is mainly space, which is environment, infrastructure, building, whatever is there within space. Tools related to whatever, from medications to instruments to ambulances to whatever we need something in handy, or it could be as simple as HIM people, as in, of course, the team that you're working in. And on top of that, how do we utilize these things and under governance, which essentially means policy and procedures, processes, organizational structure, and so on and so forth. So, sometimes when we talk about, let's say, stroke rehabilitation, I did not want to jump onto stroke rehabilitation to start talking about patient care in terms of clinical perspective, because we all know that majority of our experiences and challenges may not be coming from the clinical side of rehab, but they are essentially around these aspects. When we talk about space, let's say, patients do not have access by ramps in a hospital setting, or they are in a shared room with the experiences may not be optimal. Similarly, you're an expert, you have an expertise in something, but you're not able to provide that expertise because we don't have that tools to be able to provide that. Or sometimes, we are unable to provide certain equipment to a certain patient, which can impact their care. So there are like different elements, which is very important. We understand and we know about these aspects anyhow, but I wanted us to keep that on the back of the mind, that these things are extremely important, which can impact any disease group or any patient group. Now, coming to the operational factors, again, the three things I would like us to focus on is, these are the three things which are not very well emphasized on when we are dealing with patients. Again, I don't want us to jump on to stroke rehab. I want us to, consider these factors which we all know about, but I would like us to give an equal emphasis on these things as well, which are normally we are expected to do, but the emphasis could not be really reaching to the optimal side. Now, it talks about three things: the person, which is the patient, and his or her support systems, you as in as a provider and healthcare team, and your support systems, like our support system, and what are our limitations as well. Because whatever we do or whatever we provide in terms of care is supposed to be operating within these three dimensions. So for example, what do I mean by the person? Yeah. So what do I mean by a person? I want to consider a person as in person first. What do you call that? Person first approach, which is instead of calling the patient, we would call them a person first approach. Family and support systems, socioeconomic circumstances, and knowing what is important for them. So we have often come across patient-centered care or person-centered care. So it's extremely important. It is important for us to know where they're coming from, what is their background, what are the possibilities they can comply with continuity of care. This is something that we routinely know, but if I start talking about stroke rehab directly straight away, and I do not emphasize on these aspects, I think the practical aspects would again be more of a theoretical knowledge. So I would like to emphasize on the person-centered care as well. So speaking of you and your team, now it's a very, very important that we need to be self-reflective of how much we have the ability, and we probably have to be very open and clear about it. How much expertise do we have? How much experience do we have? What is our comfort level of certain things that we can do and we cannot do, whatever our preferences as well. And above all, I think what is impacting us on day-to-day basis is our own health can reflect on the performance of the team as well as the care of the patients as well. What are our personality traits? How much commitment and discipline do we have to be able to provide care to that stroke rehabilitation program, right? So again, not to jump onto the stroke rehab, this slide is particularly about self-reflection. Obviously we know all the CanMed's competencies, like where do we stand in terms of a collaborator, advocate, and medical professional and leader. So all the things we need to calibrate by ourselves as well, because that will amount to the practical application of our knowledge. Again, the team, we know our team the best. Are they having appropriate caseloads? How is their experience like? How is their personality likes, right? Competencies, reliability, responsibilities, how is their aptitude towards learning, are they effective collaborators, and how is the team satisfaction too. So these are the foundational factors which can add on to the clinical knowledge. Generally, when we are doing presentations, when you're doing discussions, grand rounds, clinical discussions, we limit ourselves because I think as physicians, we tend to more glamorize ourselves towards the clinical aspects of things. We have adapted that role, but once we enter, all of us know that once we enter into the real world, the reality is around these aspects. Now, what is our support systems and limitations? Space and infrastructure. We talk about ideal or best possible rehabilitation of stroke survivors. Do we have the relevant space and infrastructure? Can patients access the specialized programs? It could be as simple as distance from home. It could be as simple as outpatient services. And again, is everybody doing the job assigned to them effectively, efficiently, or not? What is the leadership approach towards a certain program-based care? What are the payer system? Who's funding it? Government is funding it, insurance funding it. Things are changing as well, so that is going to play a very, very important role in the practical application, right? So I would like us to keep that in mind, that we want to apply whatever subsequent discussion we're going to have about stroke rehab. These things are going to be the foundation. In fact, for the next week, in terms of spine and all the wonderful schedule that we have, these things are going to be affecting those aspects. How much administrative understanding and support that we have across all levels. How is the electronic medical record system? Is it optimized? Is it as a barrier? How is the policy and procedures? And how is the compliance to the policy and procedures? What is the trend of the program towards compliance of the policy and procedures? Are they able to do that? It's not that they are not doing, are they able to do that or not? What are the troubleshooting pathways? What is the standing of the institute in the country or in the region, et cetera, et cetera. Right. So now I would come on to the disease group specifics. So today we're going to be talking about stroke side of things. So number one, I would say that know the stroke statistics and relate them to the patient. This is extremely important that we continue to retain the statistics around stroke and rehabilitation and different aspects of stroke care, starting from epidemiology, right? Where does this discussion really work? Majority of these discussions would help, a majority of this knowledge will not only help you as a clinician, personally in terms of your clinical understanding of the patient, but I think most of it will help us to communicate with the team, communicate with the patient and the family. So this statistics, the knowledge of statistics can be extremely important in family meetings, right? We should be able to understand and remember clinical stroke characteristics. What is the etiology? Majority is ischemic strokes. What is the outcomes and prognosis of hemorrhagic strokes? What percentage is the impairment? How is the prognosis of upper limb, lower limb aphasia, bowel bladder incontinence? How do what are the chances of having another stroke in 1 month? What are the chances of having an MI within a week? What is the most common cause of death after stroke? Now, these are the things that we can use to answer majority of the concerns that the patients have, which is around this. What causes a stroke? How common is it? Have you seen some patients like this before? Is my hand going to work or not? How about the continence? Am I going back to a normal or not? What is the what is the chance I can have another stroke, right? So the knowledge of these things are extremely important, statistically evidence based, and our standard books like DeLisa, Branham, and Board Review have these very nice summary of tables where we can remember them. So it's about 5-6 pages, so one can make it. You can have this on top of your head, and as you go on, do the discussion over and again, you kind of remember them by heart too. So again, also know your own statistics. What are the international statistics, Saudi statistics, institutional statistics, your own experience, and if you want to talk about and convince patients about procedure, you can mention your numbers, you can mention your complications, or whatever outcomes you had. Similarly, when patients are having a hard time to comply with, let's say, their medications in terms of diabetes, hypertension, they're still insisting on smoking and everything. So we can use the point number 2 here. We can mention to them that you have a higher chance of stroke within the first month, and that's why it's very important to control the risk factors because of which you had a stroke, which is essentially related to your smoking and your hypertension and your compliance to diabetes and stuff like that. So I cannot emphasize more as a rehab physicians on the knowledge of statistics here. Yeah, so this is important. I think this why should be there not only in terms of stroke, but it should be there probably in any disease process. But I would typically want to mention in reference to a few things on stroke. Why the patient had a stroke? Why this patient had medications? We really need to have a very good grasp on what was the location of the stroke, how does it anatomically correlate to the impairments that the patient's having, what is the medication list, and why they're having these medications as well. Right, it's extremely important. This is a special message for the residents when they're assessing the patients. Please do not just copy paste and add on. Keep a backlog of a conscious effort around why the patient is on certain medications, which are certainly sometimes unusual and not common. Why any symptom happened, why there is a change in the status, why the patient is still on NG, gastrostomy, why the patient is IV. So this are all like very common scenario. Patient comes in with IV line, right? You ask them like why it's there. You figure out, oh, it's a stroke unit protocol. Patients isn't correct for like 4 months. Did anybody try to put it out? I mean, we don't know, right? Patients in gastrostomy tube, but the patient is eating normally without dysphagia for the last 6 months, right? Patient is on catheter, intraurethral. We ask them why. It's like we were discharged on there. We've never tried to remove it, right? So there are many, many whys that we really want to ask, especially anything which is synthetic. Just have a look at the patient. Anything synthetic, just ask them. Sometimes they may have defibrillators. Sometimes they may have implants as well, which may not be visible when we are assessing the patients. And the most important question, why the patient in bed, right? Again, approach care for stroke survivor with, I would say, start off with the what. And what are the problems? One way I usually, when we're discussing these cases during rounds, is a head-to-toe approach. Is a head-to-toe approach and an inside-out approach. So it's basically you point it at your head. So from head you can think of cognition. In head you think of language problems. You come down to the eyes. In head you also think of mood problems and behavior problems. You come to the eyes, you think of visual field problems, visual neglect problems, baseline optometric problems, or any retinal changes or ocular problems as well. You come down, you look at the mouth, you talk about speech and language and oral hygiene. You go down to neck, you think of dysphagia, dystonia. You go down again to the limbs, you think of hemiplegic shoulder pain and spasticity and motor recovery and sensory changes. Then you go down further, you think of continence to bladder, bowel, and skin changes. You go down further, you think of legs. Legs are very, very important when we're dealing with stroke survivors, because it's a vascular problem. So from time to time, you need to have a very good monitoring of the vasculature and skin. So inside out means, now you look at the inside out meanings, like what is there in the body, in the trunk. So it's a stroke survivor patient. It's a patient with stroke. So they do have comorbidities. So think of all the systemic problems. If a patient has a stroke, they may likely be having ischemic heart disease, hypertension problems, any lung disease, any gastric liver problems, any genetic urinary problems, any renal problems as well. And they may have any history of surgery or trauma in the past. So this is like head to toe, inside out. It's a very comprehensive way of, I think it's a very comprehensive way of approaching and remembering patients' problem list. And then, of course, as a rehab physician, we have to look into the functional aspects of patient. And what to do about it is, I think, is a routine. That's where the active rehab comes in. Rounding. Would anybody would like to volunteer if one of our residents from KFMC who may have done their stroke rehabilitations? Typically, if anybody could, recall how do we round, or how you used to round. When we go and when I used to go there and do the weekly round, what was the approach? What is the first thing that we open up? Any resident from KFMC who may have rotated with me in the past? So typically, hello, can you hear me now? Okay.
Yes,
Is it
we can
clear?
hear you, Dr. Roy. Yeah, it's clear.
Okay, sure. So, what I wanted to say was that, for example, when we are rounding, this is how I used to approach things back then. We look at, number one, the vitals. The vitals are important for any patient, especially for stroke survivors. Two, the vitals tell you the story of, what is next, what is happening now, and what is next to come. Medication list, I cannot emphasize much on the medication list. If you have 5 minutes to do a consult on a stroke survivor, and you have to know, am I dealing with, what kind of patient I'm dealing with, just review their medication list. So that will tell you the story, what happened in the past, was it thrombolized or not, what procedures they had, and what kind of medications they're taking now, and that can hint you and tell you exactly what's going on with them. Labs would be another thing that, during the rounds, we review the labs for sure. From time to time, we are monitoring simple things like if a patient has infection, WBC, patients having, electrolyte imbalance. These are the typical couple of lab monitorings that we tend to do, right? Functional status, equipment, discharge plan, and every day, these things: sleep, mood, pain, appetite, hydration, incontinence. This is what I emphasize a lot when approaching patients with stroke. Mainly, the thing is that these are the things which anybody, everybody, and each one of us is affected with. Imagine yourself coming for a busy day in the morning. Let's say you're expecting to come over where you have clinics, consults, and you're expected to do an inpatient as well, and you did not have a good sleep, right? Your care, your performance would be affected. Similarly, patient's performance is affected as well. You don't have a good mood, you will not be able to focus much. You have some heel pain, back pain, plantar fasciitis, headache. Your focus is out. Uh, you didn't get a chance to take dinner last night, or you didn't take a breakfast in the morning. You have been dehydrated because of, let's say, whatever sports activities you have been doing, or maybe you've been out in the sun for a long time. So these are the things which we apply on ourselves, and either of these things, if they go out of order for us, we are affected. So you can very well imagine that what happens to patients with stroke, or geriatric patients, or any patient in general, especially geriatrics. We have seen those patients, they don't sleep well. The next day is totally off, not in a good mood, no participation, pain, doesn't want to get out of the bed, loss of appetite, fatigue, lethargy, doesn't want to do anything, dehydrated, not in the usual state of health, right? So similarly, continence problems, mainly, patients are having wet diapers, wet dress, wet bedding, and bed lining, and that is causing annoyance to them, and so on and so forth. So I would emphasize these things, the last few things that we need to ask all the patients, especially in geriatric patient group. So stroke care is generally geriatric care. High emphasis on comorbidities. We really need to be, as physicians, we really need to emphasize a lot on understanding of medical problems in geriatrics. We need to be able to familiarize with the management and ask for help or consult whenever we have to. And this is one of, I think, one of the best things that I had at KFMC was that very open sharing of problems with the colleagues, and uh, similarly, likewise, we used to ask each other for anything which is not clear to us, which could be as basic or as advanced. So, for example, I remember one patient we had. He was classified as a hemorrhagic stroke, and later on, we were not sure because the patient had a renal cell carcinoma under workup. And we know that it can metastasize to the brain, and it's very difficult in the acute phase to be able to differentiate between a brain tumor and a hemorrhagic stroke. So later on during the workup, we were the one who initiated the workup, and the patient was diagnosed to have a brain metastasis. So it was not a stroke at the first place, right? So these are the things, and the patient was guided to the right service later on, right? So there are unlimited examples. I'm pretty sure that, yeah, one of the other colleagues, he had mentioned that the patient was admitted through acute stroke service with hemi weakness, and was continuing to have progressive hemi weakness, which was significant, and it was more suggestive of spinal cord problems. So the patient was investigated on the rehab floor by the rehab physicians to be diagnosed as cervical myelopathy with hemicirculatory syndrome, and patient probably never had a stroke to begin with, and the patient was transferred to spine surgery, right? So what kind of screening, risk stratification we need to keep in mind, right? So our usual list is the same. I would always keep screening when we are screening patient. I would emphasize again and again on the vitals and the neurovitals as well, the conscious level, and make sure, especially if there is an acute change or sudden change, where a patient is delirious. Geriatric patient stroke survivors are very tricky. They are not in the usual state of health because of 4 or 5 very common reasons. So common things, common first, they may have infection, they didn't have a good sleep last night, they have medication side effects, they have drug to drug interactions, they are constipated, they have electrolyte imbalance, or maybe they had a silent MI in a patient with aphasia and they're not being able to express what happened like 2 days ago, right? So common things, common first. Mild infection and dehydration can cause sudden change in stroke survivors. One of the greatest challenge in stroke survivors, probably like younger pediatric patients, is that they're not able to express themselves with language impaired patients, which is almost 1/3 of the stroke survivors. They, so the delirium is tricky, right? They will not be able to answer you. So you will have to have a very focused eye on clinical examination. What other risk stratifications: falls, VTE, osteoporosis, fracture, dysphagia, dyslipidemia, hypertension, thyroid, and diabetes. These are the things we really need to really screen the patient for. One very important thing, which I guess is quite underemphasized, it was included in the AHA guidelines and then later on removed as well, which is the obstructive sleep apnea, right? So stroke patients may have obstructive sleep apnea 30 to 70%, right? So, and it is identified as the risk factors. It's a very huge question mark that, with such strong relations, why this is not a routine screening. I think it needs to be in acquired brain injury protocols. What kind of post-angiography and thrombectomy may have? Patients may have radial pseudoaneurysm, femoral pseudoaneurysm, hematomas in inguinal region. It's very rare things, but many times you just read about it, but you cannot probably pay attention to it till the time you actually see it. So they started doing femoral pseudoaneurysms are known to us. It is very relevant to us because patients from subacute, acute care, thrombectomies and angiography from the inguinal area, they're usually on anticoagulants or antiplatelets. For acute care, a small hematoma might not be, central sleep apnea. Thank you, Dr. Noura, for mentioning that. So may not be able to, for them, it might be from acute care team or acute nursing team. It's just a small hematoma. For us, it is very important because we have to mobilize the patient, bring them out of the bed. We have to move that hip, right? And especially if that hip is on the affected side, it's going to be a challenge. Patients on antiplatelets and anticoagulants, and you don't know what's going on, right? So we have seen those pseudoaneurysms in the femoral artery. We have I've seen a patient, a radial artery. They started doing intervention through the radial artery now, previously at KFMC when I was there. So they have seen radial artery aneurysm. And again, for acute care team, it's just a radial small, or vascular team, it's a small pseudoaneurysm, conservative management. But for that particular patient, that patient was very young. I think she was 18 or 19. That was her right hand. She was having good functional recovery in the right hand. The aneurysm was in the right wrist. We had to mobilize it, use it, and that was making the aneurysm, and she was on anticoagulants. That aneurysm was increasing and making the skin to an extent where it was about to erode. So those things we try to do conservative, but it was a difficult balance between managing that pseudoaneurysm while the patient was undergoing active rehab for a otherwise very good prognosis for a hand. So I remember one patient we had, she had a femoral access for her angiography, and angiography in the brain went, or whatever procedure, I'm forgetting on the procedure itself, but access was through routinely inguinal area. And but again, we have to remember that stroke is a vascular problem. Vascular atherosclerotic disease in the brain means it could be the heart, it could be the leg, and it could be the femoral artery itself as well. So if we irritate the femoral artery, there's always a chance, or there's some chance that plaque, if there is a plaque over there, that can dislodge distally and going into the peripheral artery and cause limb ischemia. And this patient had to be she had this complication, which was diagnosed on the rehab floor, right? And she was transferred back, where she underwent salvage treatment, but later on she ended up having, I think, a couple of toes to be amputated, right? So it goes a long way. These are something very stroke specific, very practical, but rare. But I think this is one of the purposes of these sessions, is to be able to share similar cases so we can watch out and always think about these things which are rare, but they can have a high morbidity as well. Antiplatelets, anticoagulants, I cannot emphasize on more. Again, as I said, like, we have to be able to look into the medication regime very closely, and we have to question ourselves why the patient is not an antiplatelet if patient is having ischemic stroke, vasculitis, rheumatological problems, right? So we have to be able to know, like, if it's a vasculitis, rheumatological problem, what is the active treatment for those, going on, and the patient should be able to tell you most of the times that their treatment is used every 6 months, or they were on immunosuppressants because of the stroke. It was held on. They're going to go back, and that can have a huge impact in continuity of care of the patients too. Why or why not in double antiplatelet? For example, if you see a patient with acute lacunar stroke and you don't see them on double antiplatelet within 3 weeks, you should really question yourself. And it should not be of surprise that maybe during the transfer on a weekend night, something happened and the medication order could not be written down, right? And for example, if the primary team comes in and if you're not able to put in, oh, that's a lacunar stroke, I really need to see if the patient is a double antiplatelet or not. And maybe he or she was an double antiplatelet, but now he or she is not. So similarly, there are 2-3 other indications where the patient is supposed to be double antiplatelet, right? We need to be aware of those indications. And if not clear, this is not our call to be able to decide that. We should be able to call the neurologist or the prescribing physician or primary physician to be able to make that call, right? Why or why not an anticoagulation? You have a patient with atrial fibrillation or recent PE or VTE. That's something, we should freeze in time. We should really thoroughly investigate why the patient is not an anticoagulant while the patient is documented to have a recent PE in the previous hospital, or while the acute care, what exactly happened. Did they put the IVC filter in? If the patient is on IVC filter, we have a limited window to basically remove that IVC filter, right? So we need to kind of sometimes take care of those coordination of care aspects too. Why or why not on antiplatelets? This is a common dilemma that we come across in rehab settings. Why this is important? Because obviously antiplatelets is established to have, anti-epileptics are established to have poor prognosis if they have side effects of sedation and on cognitive recovery too. So that could really impact us. So if the patient is, sometimes they're on high doses, sometimes they're on phenytoin, which is not the desirable one. But sometimes it's used in acute ICU settings, and once it's started, it remains there. Sometimes it's prophylactic, sometimes it's empirical. So yeah, so those questions are important to be addressed on the rehab floor by the rehab physicians, I would say. Why on medication doses which don't seem right? Why the patient is on, like, Keppra 250 once daily only, right, for 2 years or maybe 3 months, right? Why the patient is on combination of medications which don't seem right, why the patient is on double SSRI, which you cannot explain, right? Why the patient is on double beta blockers, something like this, right? So sometimes they have drug-drug interactions as well. Patients on tramadol and SSRI, you want to keep an eye on the patient too because of serotonin syndrome. Patients who have had craniectomy, this is like, and yeah, that's a very good add-on from Dr. Shahid Jabali, that Dr. Shahid is suggesting to add benzos for patients who are known to be epileptics. Thank you. Yeah. So every hospital has a seizure protocol. So if you have in your EMR, you have a seizure protocol, or you have a policy or CPG seizure protocol, please include that for all patients who are known to have seizures or who are at risk of seizures too. Where is the, when was the craniotomy done or craniotomy done? Where is the flap? I mean, where's the skull part? And it's in case of cranectomy, I would want to say here. And when is the plan for putting it back, right? So these are important things because we know that the barometric changes are there, atmospheric changes are there in patients who have a cranectomy. And also, it's very important to know when it was done because we want to have it as early as back. Routine is that around 3 months time, the edema settles down and we can put it back. But sometimes in younger patients, and there is a trend and recommendations and evidence coming up that it can be put back in early as well. And why not? Patients do generally tend to improve neurologically functioning because of the barometric changes and atmospheric pressure changes as well. And they are at a higher risk because atmospheric pressure is higher, there's no bone flap there, and such things can lead to sinking and flap headaches, and they are at risk of herniation and hydrocephalus too, right? So again, this is something that we want to keep an eye on, and we can coordinate with the neurosurgeons depending upon which center you working at, or what is the accessibility and what are the dynamics to facilitate that. Now, this is tricky. Command following ability. Do not be misled by aphasia, cognitive impairment. Sometimes patients with language impairment, mixed aphasias, and receptive aphasias, if you give them verbal command, they will not be able to process them. If, for example, if you ask them, open your mouth, and they're not doing that. Close your eyes, they're not doing that. But once you go out just to ask anything to the nurse, you come back and patient is actually, eating by himself, right? Or grooming himself or herself as well, right? So uh, test such patients with, extending your hand, saying, spontaneous speech as well. They are much more non-verbal, uh, cooperative, patients who can follow your commands non-verbally with gestures as well. So especially very, very important in your screening in the clinic, as well as khasusan in the acute care, because where there is delirium, there's language impairment, there's cognitive impairment. You go in the morning, the patient is totally knocked out. You go in the evening, the patient is eating by himself, right? Or is even sometimes going to the bathroom by himself, right? Or patient is doing that. And the patients, when they tell you that, no, it's just the morning that, he's like this. In the evening, we are going out and, he is, opening, he's dressing, undressing by himself. He can wear the shoes by himself sometimes. So these are all very good indicators. So please do not, what I would recommend is do not be misled if the patient is not able to follow one-step commands by verbal uh, instructions, right? So non-verbal gestures are extremely important in patients with aphasia and cognitive impairment. And the vast majority would surprise you by participation as well, and they may do good physically in terms of their aerials. All right, so yeah, we are familiar with the stroke rehab team. So this is a typical pathway for stroke rehab, where the patients have acute stroke services from emergency. They come on to acute stroke unit. From there, they're transferred to other hospitals, units, or community or clusters now, as we know, or they are transferred to outpatient rehab, daycare rehab, or home care, or they can go to long-term care as well, or they come to inpatient rehab facility from the acute stroke unit or from other hospitals, and from there they are discharged to home or long-term. So the only constant should be is the only optimal constant should be, I think, as parallel to their other aspects of care, is and should be the rehabilitation at all the three phases. I personally believe that in working in our health system, communication and patience is one of the traits that we need to have when we're dealing with, especially with stroke survivors, right? And the background for that is that a WHO definition of health is a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. What I want to bring to knowledge, and obviously everybody knows about this from rehab background, but just another view of looking at it is that stroke is not a cerebrovascular entity only, but an entity affecting patient, family, and their role in society, right? So stroke is not a disease of blood vessels. It is a disease of, or you can say it is something, it is a disease which affects the patient, family, and society as well. So One of the approaches that I would suggest, and I adapted that in my practice, was to reverse approach the patient, rather than focusing on neurological impairments and emphasizing on their functional impairments, emphasize 10x, like emphasize much more on where they're coming from, who are they, so you can understand them and you can, help to facilitate their integration back to where they're coming from. And that's where their anxieties are coming as well. So communication would be, something optimal, and patience would be required as well. The definition of quality of life is individual perception of the position in life and the context of the culture and value systems in which they live in relation to the goals, expectation, standards. So it's not what I think is the quality of life of the patient, it's what they think is their quality of life, it's what determines it, right? So that having said that, we need to not prioritize what is most important for us, unless obviously that's clinically, relevant and important. We always keep as, the goals of the patient and the family in mind. I would not say person-centered care. For rehab perspective, it's always patient and family-centered, and the ultimate goal of rehab is social empowerment. So that is why I think the reverse approach, thinking about their position in the society, understanding the patient and family dynamics, make a very good rapport with the patients, can help you achieve the neurological and functional goals to their satisfaction, because they are the ones who are determining the quality of life, right? So, and team well-being, I think that's the core of, how we can effectively deliver the care to the service. The team has to be gelled well, and they have to have a good understanding among each other. So evidence-based rehab is, a combination of three things, right? We usually consider that evidence-based rehab means like best research evidence, what the literature says, FLA article says, FLA meta-analysis status, FLA guidelines stated. This is one element, right? So the other elements of evidence-based medicine is clinical expertise, and this is what we're talking about, and patient values, what the patient wants. So this is I would say underemphasized aspect. Let's say if somebody has certain experience of a certain domain, and they have certain recommendations of doing something within, obviously, certain safe and effective treatment protocols, that adds to the evidence-based medicine, right? So whatever is applicable in the US or Australia may not be applicable in a government hospital or public hospital in Saudi, or vice versa. So what are the patient family related challenges in stroke care continuum? I'm sure everybody has gone through that. That's why, in this presentation, I'm focusing on the non-clinical aspect, because that's where the challenge is. That's where the focus needs to be, right? But in terms of our undergraduate, postgraduate training and examination evaluation and systems, we are by the book, on the evidence, we are on the purely on the clinical sides, or mostly on the clinical side. But once we add on to the actual practical workflow, many of the challenges are unrelated to the clinical side, and we find ourselves as rehab physicians, we do find ourselves consumed with a lot of problems related to non-clinical aspects too. And I think it was Dr. Noor had mentioned that they would prefer to have a stroke healthcare educator as well. We'll see. That is very important. I would not. I totally am with you on this, that education in one form or the other is important. If you have a stroke education or educational health educator with you, that it would be great. But sometimes patients, they do, in our health systems, usually they look up to the physicians or the consultants to be able to reinforce and reemphasize. So that is, and by the way, this should not be taken as a negative. There should not be any blaming, shaming around it. This is rehab, right? So this is our system. This is the normal here, right? Patient approaching you for minor questions, or they want to be re-emphasized, and again, over and again, right? That's a routine, whichever part of the health system you're operating in. So I think we need to be adaptive towards it, and we need to be understanding towards it. This is a part of the rehab that we are expected to manage. Yes, it can be optimized. It can be better. It can be shared care as well, as you mentioned. If we have specific health educators to be able to do that, why not? This is the ideal and the optimal. So, what happens in the acute care with stroke survivors? This is important because now this is in hyperacute stroke services is because it's a national program. So the clusters are trying to go more and more in the acute phases. So they would have the rehab to be integrated there. And there is a move towards having inpatient in the MOH hospitals as well. And there's a greater flow or the greater trend of opening up inpatient services as well, which offer acute care stroke services, right? So this is important. In the next 4 to 5 years. We should be able to see a lot of acute integration of rehab services, which is a good thing. So in the acute phase, what happens? The majority of the traumatic events, be it a vascular event or a trauma event, right? So they could be very life-changing. Patient is doing fine. Within half an hour, 1 hour, they're hospitalized with a significant disability. It is unbelievable, unimaginable for anybody, any human being, to be able to process that, be it the patient, the family members, because they may have witnessed somebody who had a stroke or a spinal cord injury or head injury. They have experienced somebody in their life, or sometimes they would not have anybody who have gone through that, and that could be counterproductive because they are thinking, oh, patient thrombectomy done, and our patient will go to rehab, and he or she would be back to normal as per their expectation and definition of normality. So they are unable to take too much information at that time, and at that time as well, it's probably not very realistic and practical to talk about a lot of things. And this is by virtue of experience I've learned as well. Do not overload the patient in the acute phase and the family as well. There is so much going on in their life, the family's life, and the patient himself or herself. They will not be able to process or retain. And when we document that, we have discussed the prognosis and the length of stay and the instructions for the watcher, and the prognosis of the hand and the goal. I mean, we should not be surprised by the time they come to us, they don't remember that. Lack of understanding and patient or family and the acute stroke, as I said, they may not be aware of what's going on. Family dynamics are heavily disturbed due to hospitalization. They have not even thought of disability or outcomes yet, as I mentioned. Preset beliefs in stroke. As I mentioned, they may have their own perceptions of stroke. They had one family member who had a stroke and he or she did well. The last stroke was, I was completely back to normal, right? So they have a preset belief that, oh, this is just a stroke because I did well, dad did well, or mom did well. So, it's just a stroke, as they had a stroke last time and they did well, which may not be the case. They have not even thought of disability or outcomes yet. Again, we will go back to rehab. We'll go to rehab and everything will be normal, right? So again, this is sometimes we are conveyed very often that, nobody told us about prognosis, or we don't know about anything about the prognosis, right? In spite of the fact that they have been told, right? So it could be a perception thing. It could be that they were told or they were misunderstood as well, right? So it could be either of these things. So even if somebody comes up and says such a thing, I think we need to encourage ourselves and our colleagues, everybody, and the residents as well. That's fine. Start it over. That's okay. That happened in the acute care. Now they're coming over again, and we have to kind of revisit this with them. And again, it's psychosocial. It would be one brother, maybe the next day, this next brother as well. We need to streamline as much as possible. But that's how the system currently is operating, right? So we have to kind of manage things around it in the goodwill of patient care, and also making sure that you don't run into burnout situation for especially with the residents and the nurses as well. So traditional treatment, patients are very fond of traditional treatment here. It's very popular. We should not underemphasizes. We cannot ignore this. There's one research which was done in last like 2020, and it shows that majority of the patients had a cautery done as well, and you can see the majority of the CAM use, complementary internal medicine, was while they were hospitalized. So that's interesting, and we come across these situations where the patient goes out and pass, they comes back with a COVID. I think we have all of us have seen those cases a lot. And they told about their care. I don't remember anybody really basically hid it because it's very obvious. But many a times you do come across a situation where patients, the doctors were not informed, or the team was not informed about the possible plan of COE, a burning treatment. So understanding social cultural attributes, a very, very interesting, very interesting study. Dr. Mohammed Kahtani, maybe our colleagues in KFMC, we remember Mr. Kahtani. I think he was our psychologist back in old days. So he had published this study where it mentioned this is basically expression of the patient. Stroke is perhaps a neurological condition least well understood by patient, most likely to be associated with a wide range of cultural beliefs. Evil eye, more than half of the sample attributed to the evil eye, linking to a stroke to faith, and so as the statements are stated here, as described by the during the survey regarding stroke. So very interesting article, and that tells you. So these are the things we really need to consider when we are approaching things. One similar thing was 70% of the mothers, would prefer breaking bad news process to involve the husband first regarding the children. So interesting, right? So this is unrelated to stroke, but 17% is that they want their husband to be informed about the prognosis or the problems regarding their children's medical issues or disabilities rather than themselves. Now, nursing is a backbone of stroke care, and so was the Saudi national nurses range went from 9% to 38% in, I would say, 20 years. And expat, which is non-Saudi nurses, are still 60 to 70%, which I would imagine that are from Philippines and Indian. Now, why I put this over here is because it is extremely important. This is not only for rehab physicians. This is also for our rehab physicians who are coming from different backgrounds to, let's say, Saudi health system, even from Arabic background or non-Arabic background as well, that we should have to be able to understand the cultural aspects, which are mentioned in the last few slides, and considering and claiming to be rehab providers, rehab healthcare providers, we need to be very open towards adapting to how things are here and how we can improve things based on the service provision, keeping the cultural and social aspects of health system over here, right? Be it you're coming from Western health systems, or Australian or Pakistan Indian or European, whatever background we need to be coming from, that is a different story. That is a different psychosocial economic system. That is a different health system. That is a different patient group. That is a different cultural social aspects. They have their own challenges, which are so extraordinary and sometimes so unbelievable, especially when it comes to social and cultural aspects of their lifestyle. That we need to be, we do adapt ourselves over there. Similarly, we need to adapt whichever part of the world we are working in. So this is the power slide. Why I build up this case up till here, that we need to have stroke and stroke culture competencies of staff in specific, right? There has to be sensitivity to elderly treatment, sensitivity to clothing, privacy, cleanly, and toileting preferences, understanding of the position and family, understanding the dynamics of patient involvement could be different from elsewhere, sensitivity to gender roles, sensitivity to religious preferences and practices, understanding of communication attributes, facilitation to improve language skills as well. And currently, still, majority of the rehab institutes, to my knowledge, they still have expatriates as the nursing majority who are in the forefront. And as I said, like nursing is the backbone of rehabilitation care. So as rehab team leaders, rehab physicians, or even, we need to expatriates like myself and colleagues, we need to be very, well familiar with the culture sensitivities around it, and we should be very open around it, whichever part of the world we are. Not only in Saudi, even outside, even we are going to other places. We need to be very open and understanding, and we need not to be judgmental. That's very important as well, right? I think that's where we need to emphasize more and more in terms of mentorship and training and role modeling as is carried out when we go abroad for fellowships and so on and so forth, right? So attention disability, understanding of stroke-related disability is extremely important. The patients and families do not understand that in the so much overwhelming phase. There's a lot of expectations and denial. One common status, as I mentioned, nobody told us anything. It could be that they could not remember. Simple. It could be they could not understand. Most likely, they have not read the books. They don't have any idea what is jalta meaning, right? Is it a bleed? Is it a ischemia? What does it mean? Like, where is it happening? Right? Is it a blood vessel problem? Is it a brain problem? Right? So people, we need to kind of go down to the basics of stuff. Denial and want to listen from another doctor, right? So they might be in a denial, and this is not an uncommon um, situation. I think it's a human behavior. It's a defense mechanism. Sometimes we do that as well. If we are not convinced about one person's opinion about any aspect of our life or any important aspect of life, we do kind of try to go to somebody else and find a solution which is more favorable for us, that we want to listen. That is, somebody can say yes to this thing, right? So we can take a yes from somebody, right? So this is a very humanly thing, and there could be a possibility they were actually not told about it. This is quite possible as well. But again, as I said, like, it's not the time to be judgmental. How is it possible you had a major stroke and nobody told you about anything, right? So we don't want to go into that extent, but we want to address whatever the problem is, take it on the face. Family or new family members coming, they're expressing that they don't understand, they don't know. That is the time to win the confidence of the patient and the family. That is the time you want to develop a rapport, because that patient is going to be with you. If you're in a public setting, definitely that patient is going to be with you for a few years. And your management plan, our management plan, depends upon how much effort the patient and the family are going to put in, right? So family members are our resources after discharge, who are determining our success of the outcomes of the treatment that we have done for the patient, or we want to do for the patient at home after discharge, to achieve a prognosis. So there needs to be, again, as I said, communication in patients, old age, genetic care, I think extremes of age. I think that is what similarly relevant in pediatric patients, I would imagine too. Right? A common scenario, somebody informs somebody else who could not pass on. Very common scenario. Whatever with teaching you've done for one patient, it kind of goes away for the next week. You can do one time, twice, and then sometimes you kind of tend to give up. That all right, so we need to have a dedicated watcher. We all know how integral it is, a dedicated caregiver or possible dedicated caregiver in continuity of care of the patients during hospitalization and after hospitalization as well, right? So this could be, I think this should be an institutional project, at the highest level, because that determines our prognosis. Whatever we're doing in terms of toxin and pain management and mobility, if that is not carried out the day after discharge, we are going to lose a lot. And no wonder when the patients are coming to us after 3 months or 4 months, they're back on catheter, they have skin problems, they are deconditioned, debilitated, right? And we do remember that we have discussed everything and each and everything in detail. But again, this happens, right? So we identify it, we take it again, we take it from there, and not giving up, inshallah. So sometimes we give too much information. I think I've learned it the hard way that we need to give we need to be very individualized when we're giving information, especially in family meeting, because when we're doing family meetings, we try to give uh, more than better. I think it's sometimes not the case. Sometimes it's not very productive. They cannot retain that much information about prognosis of language and walking and returning to work and what's going to do after discharge, who's going to be giving the equipment, right? What about the urologist for BPH? What about the dentist? My echo result is not out. When is my, so this is too much information. So I think we need to individualize our talk based on who's sitting in front of us, right? That's where, going back to the first few slides that I mentioned, establishing a rapport with the patient and family members is the most important and integral thing. All right. So social dynamics, again, the same things I pretty much covered, right? Not a very uncommon scenario when the family member most involved with care is not a legal next of kin as well, right? And that is something for a discussion and debate. I think there's an ethical debate as well as to how to approach this situation, because this is a very common situation uh, in our health systems, especially patients who are coming from abroad, right? From outside Riyadh. Okay. So socioeconomic problems, as I said, are same anywhere else in the world. The nature is different, incidence is different, and other problems are different, right? So you go to any Western countries, motor vehicle accidents, problems, alcohol, right? Weekends, alcohol, right? And so their problems are different. The emergency visits filled with uh, substance abuse, recreational drug abuse as well, right? So, or again, opioid dependency. So these are the things which are their challenges are different. The social dynamics are different as well. So I think we need to have a very neutral approach and open approach towards whichever part of the world we are in to handle patients with stroke. Okay, continuative care. All right, so we I think we are all familiar with these situations and challenges. So if you look at this slide, I'll go back. Yeah. So if you look at this slide, this would be something. These are our major problems. I think if you ask anybody in our health system, what are your challenges? The clinical challenges do not come forth first in our mind. The non-clinical challenges come forth in our mind, especially in geriatric, especially in stroke, especially where there are acute, subacute, trauma or vascular problems coming in, or sudden onset disability coming in. So that needs to be streamlined. I think that needs to be highlighted, and that needs to be probably given more priority. Let's say when we are moving towards making guidelines, any national guidelines as well, right? If you open up any stroke guidelines again right now, you would find that majority of the guidelines, I would say 90 to 90, more than 90% of the guidelines are mainly on acute care, right? Or vascular management. Let's say vascular aspects of stroke care. So yeah, so family meeting is an important intervention. I think that was stroke rehab program was slightly, we had the leverage that we had a stroke unit as is still there at KFMC, right? So or wherever it is, like for example, if you're working in a tertiary care hospital where there's an acute stroke service, I think one of the experiences that we had was that the family meetings prior to admission, at admission, and discharge really helped a lot to settle down the anxieties and help out in the social dynamics. Yeah, as somebody pointed out, we need to have the relevant people to take the responsibilities in terms of social aspects of discharge planning and administrative aspects of discharge planning and the case management aspects. So that really needs to be pumped up. If we continue to take as rehab positions, sometimes these things fall on our shoulder as well as we're in charge. But again, we have to tweak as to how the health system is designed and continue to advocate for it, to make things better. Right. So, yeah. So this is like certain things which we commonly used to discuss during the pre-transfer family meeting. all these things in our template. I'm not sure if it's still applicable, but the initial template where we had was, emphasizing by the physician on these things. This is usually done by the rehab, but the physician needs to be well informed, because that's what will give you the feel of, whom you're dealing with, and how you can, get the family on board with you to get the things done with them, alongside them, and to help them understand your approach, and to help you understand their preferences as well. So yeah, so even the floor of the house, who's the watcher, who will be the watcher, what's the post-discharge plan. So this is started in the pre-transfer family meeting before the patient comes in as well. Initially, when we started doing that, for a couple of years, we couldn't really figure out if it's really helping or not. But when we continued to do that, I think we had a good data set, not objectively, but I would say subjectively, I felt that this is helpful as we thought it would be. Yeah. So recommendations to acute care team, again, these are the simple recommendations. Anything which we were trying to do in the inpatient, we could do that for patients while they're in the acute care. Why not? If they have the resources, again, they could at least try to utilize or. So the general perception is, and this is, I think, we need to advocate collectively in our health system, is that probably we need to have our colleagues from other medical specialties, that the general perception is that rehabilitation is a service, right? We need to advocate to change that perception. We need to change that perception, I believe, right, that this is a process, right? The rehabilitation is not a service, because once we label it as a service, we are confining that, I'm an acute stroke physician, or I am a spine surgeon, and you are the rehab, because rehab is a service. But once we advocate, we vouch that rehabilitation is not a service only, it's actually a process. Patient and family is a part of the process, and acute care teams are a part of the process. The surgeons and the acute care physicians who are treating, they're part of the process, right? Obviously, we're not stating them as experts, but once we get them on board, we can have them to, make early referrals, comply with our recommendations, advocate for, yeah, advocate for, third thing. So Dr. Jamal has asked, what are the practical points to deal with pitfalls? I would come to that at the end. Yeah, and have certain roles important in care provision. This right. So this is why we need to advocate more. So to advocate that it's not a service, it's just a process. So people get connect with us. So yeah, so I think this is one of the things at admission we want to focus, that less time in the bed, more time out of the bed. What are the admission needs? What are the watcher roles and responsibilities? Emphasize over and again. I know the case managers are doing, I know the social workers are doing, the nursing are doing, the bleep holders are doing, the security is doing that, but we continue to advocate for that and do whatever is in the best interest of the patient, right? So I cannot emphasize on much on the positioning, bed exercises, feeding, toileting, especially on the physician. I would like to share a summary of some of the projects that were done while I was there at KFMC. This is wonderful. The spasticity, goal and trigger factors. If you're on the top, you see like there's some trigger factors, and at the bottom there's some, at the bottom there's the trigger factors of spasticity. On the top is the goals that the patients himself or herself will write by themselves. And we used to hand over these cards to the patients to keep them with them in their phone, or at least take a picture. So these are the admission, review, and stroke rehab needs. Different those awareness and trigger factors for spasticity. What is the approach in patients with hemi neglect? How do we set up patients for procedures? We would have these guidelines in the in the procedure room, so all the nurses would know exactly when to position, how to position when we are doing certain procedure. So yeah, so I think that's where, I'm not sure if this is what our Dr. Jamal was referring to. I'm not sure what was the red flags about. So if you can, Dr. Jamal, meanwhile, if you can just mention about what you were referring to in terms of red flags, if you're referring to clinical red flags or some other red flags, I think I would be able to answer it more appropriately. So most common reasons of complaints and dissatisfaction in stroke rehab, right? So we all know that, right? Is the expectation of the patient to get better in spite of the evident prognosis is not matching the family and patient's expectations, insistence on admissions and readmissions. I do not think how many people are attending right now. 73 people are attending right now. So if all the people are coming as rehab physicians, I do not think anybody would not have come across this situation about admission and readmission criteria. Common cause, but if you dig deep, what are the causes? And if we put ourselves in the shoes of the patients, what is the most likely cause is burden of care. The burden of care, whatever. Again, if we can be judgmental and trying to figure out, we would find a reason, but generally it's around the burden of care. The other things could be prognostication is not understood, remembered by the patient or denied. Solution, not an easy solution. I'm on the same boat with everybody else here, but I think it's just changing the perception and finding values for help. Most of that is coming because rehab, continuity of care, where people perceive, the general population perceive that the better care is provided. The venues are very limited in Saudi, in our health system, right? And majority are at the main cities. So they have majority of the patients coming from far off. They do have a concern because we feel that yes, coming from, let's say, southern part and northern part, and you have rehab services over there, but that's what they're not denying. We have come across this reply quite often that this is the perception that they have towards certain health institutes where they prefer to take the patients to. So I don't have any definite solutions for that so far. So any solutions around it, I would certainly appreciate the input from the colleagues, from their experiences, how they're managing it. Now, in a public health system, now it's going to be private. Maybe that's going to, or at least, semi-private, or, funding would be somewhat different. That might change things, but I'm not sure if that change could be considered or would turn out to be, in favorable or unfavorable. We don't know how it turns out to be, or how the patients perceive it to be, right? Or the families perceive it to be from a disability care perspective, right? So insistence on one of the other problems is insistence on length of stay, extensions, admissions, difficult discharges, story of our life. Everybody has gone through this, day in, day out, if not every day, probably every other day. I think we come across the situation. Again, not to be judgmental, again, no blaming, shaming, I guess, around it. That's something that's part of the psychosocial dynamics of rehab. So this is what I've concluded. We kind of have to navigate ourselves around it and find values. I'm not stating that we should take the whole burden on our shoulders, but at least try to continue to advocate for it. It's number one. Every one of us has identified this problem in possibly every healthcare setting, right? So we need to be realistic, practical, evidence-based, more clinical, inshallah, and try to see and continue to advocate. I think this is more important. We need to advocate for our whatever leadership you're on. The leadership need to continue on their leadership as well. Visibility is, mashallah, improving for rehab physician all across Saudi. Wonderful, developments in the last 15 years. Probably 12 to 15 years for sure. Yeah. So so the reach is increasing, the visibility is increasing, and changes are gradual and subtle. But I believe there are the positive aspects of things. We need to continue the same trajectory with a little bit more advocacy at all levels, and hopefully, when the guidelines are made and when the national policies are made, I think that's more sensitive area. Our visibility and advocacy can help to improve these things and address those things. The solutions we know, right? But we need to kind of uh, be able to vouch for it. Yeah, and I think that's main cause: lack of optimal continuity of care post-discharge among stroke survivors, which they feel that whatever they're getting in an inpatient setting at a certain place, they may not be able to get that somewhere else, or they may not be able to afford that, or they may not be able to access that for whatever XYZ reasons. And we did have come across families. It's not uncommon when they are joint family systems where they have more than one patients with disabilities in a family member, right? So we can see that burnout, we can see the desperation, exhaustion, and frustration, and to be able to help out some way. I think whatever could be done. And obviously, at the same time, we have to consider the medical legal repercussions around it, the administrative repercussions around it, and the health systems we are operating. So we kind of have to be very intelligently handling such situations, inshallah, right? So, what is the solution? Best possible coordination of care, flexible on length of stay, if there are goals, admission criteria. I think if the institute believes that high turnover is there, and they are unable to, they cannot. It could be both extremes. That if you're not able to handle more chronic cases, then probably we need to move towards acute cases. If you're not able to handle a lot of acute because there are a lot of chronic cases waiting, probably there could be some scope of change, but it has to be official by the experts. And advocacy at all levels could be done. All right, so yeah, that's mainly it. We need to think stroke differently. It's not only the neurological disability, it's the social handicap messages. This is the reverse strategy that I would like to emphasize more and more, because this is where the problems are. Know our patients. We need to know our patients better. We need to know their background better. We need to know their personalities and their challenges and their understanding as much as possible with flexibility. Again, the philosophy is communication and patience, patience and communication. It goes hand in hand. So, so if we know where the patient is coming from or the way they're gonna go, if we know their family dynamics, they will the patients continue to start to trust you, and you can have them to be on board to do useful things which they may not be initially finding it useful, because rehab is a long journey. So even if we start exercising today, we're going to be seeing the results after a few weeks to a few months. If you do post botulinum toxin therapy sessions at home exercises today, you're going to have a long-term sustainable effects quite later on, right? So we have to get the patients and families on board to, yeah. So again, advocating with the acute care physicians and post-acute care teams too. Yeah, this is, I think we need to kind of somehow from the rehabilitation dictionary, I think we should remove the word discharge, right? Discharge is like, I started to believe that it is like it's taken as a layoff word. I know this is more of an administrative terminology. It's a hospital terminology. It's a standard terminology. But I think in real practice and in educating and sharing our experience with residents and our colleagues, I would propose that whatever guidelines and whatever publications we do in the future, we replace the word discharge with continuity of care. So even though we are doing that, but let's say uh, for example, if I have to ask one of the residents, hey, have you completed the discharge process, instead of saying, have you ensured the continuity of care of the patient, or how do you want to ensure the continuity of care? So basically, when you use the word continuity of care, the residents will certainly strike that in their mind that, oh, it's not a discharge, getting the patient out of the hospital. It's, I have to do something to ensure the continuity of care. It's not a regular protocol that I'll do PT, OT referral as outpatient, no, I know that patient has a cardioembolic stroke and he or she doesn't have a cardiologist because he or she was diagnosed here, right? He has a carotid severe carotid stenosis at a very young age. I need to have a vascular referral as well, right? I need to make sure a patient goes back to somewhere in the remote area. I have a colleague who works there. Probably I'll just make a small, message to him or her to, just accommodate the patient, right? Or just make a formal referral and guide the patients to be able to do that, right? So we have to balance, strike a balance between bed efficiency and quality of care. The emphasis on discharge and bed occupancy and bed efficiency should not, I think, probably should not go to overboard to an extent that either the inpatient stay is compromised or the continuity of care compromised. We want to strike a hard balance between the two. We should be able to express our concerns, and again, I think that that's very important as to how do you express that too, right? So we need to continue. Yeah, we need to continue to be advocating and trying to make a more collaborative approach towards the actual clinical care, continuity of care versus the bed efficiency and occupancy too. Is the patient ready to be discharged? No. Is the patient ready to continue care in the community? How about that, right? I think Dr. Jamal had emphasized and he had agreed to this notion. Staff development, cultural competency, sensitivity, and training is a must. As I mentioned, that a lot of emphasis was on sensitivity to cultural and social aspects. So that has to be integrated, re-emphasized over and again, and we need to be kind of taking the word judgmental out of the dictionary in most cases. After all, we are human beings as well, and there are situations where we have to kind of label a certain situation in a certain way. So yeah, we all have been there, but so that's very important. Role modeling, support systems, extended supervised work before actual responsibility. Philosophy of care in stroke survivors is again communication, patients. I strongly believe that neurologists and acute care physicians need to consider establishing core competencies in rehab, training and post training. Usually, the stroke fellows they come, when they have completed their fellowship. I think it should be the reverse. This is what I've suggested and advocated for with acute stroke services and the fellows as well. They really are keen in learning and understanding about rehab. But that can make a huge difference. And I think the boundaries between different care providers um, probably needs to diffuse a little bit. That's my personal take on it. Among the acute care versus the rehab physicians, either there needs to be slight overlay of things which needs to be advocated just in the best interest of the patient, right? But I think that requires a lot of competency and training changes, hopefully in the future. So yeah, process modification, how to change the process now, right? Or optimize, let's say if you're trying to make changes and if you want to make things better. Well, team building, as we all know, is extremely important. You're as good as your team is. Simple. As rehab physicians, our outcomes are functional oriented, our outcomes are social empowerment, and those are mainly handled by our colleagues and in the rehab team. And so gel with them is extremely important. And so I think before that it's an acute care, now it's a subacute care, now it's an inpatient rehab facility, now it's a chronic care. I think that has to diffuse a little. And this is my personal opinion only. I think that has to right. So I'll come back to your question, Dr. Ahmed. So so in acute care, yeah. So I think that has to diffuse a little bit, and some of the things, our colleagues either, because if you're not able to be there in acute care, we need to build some systems there. Some maybe nurse care managers or coordinators or therapists might be able to apply some of the things there before the patients. It doesn't need to be phasic. The conventional model is that the more this actually happens quite often. But I think it's quite debatable as well that the more chronic the patient is, or more immobile the patient is, they are sort of naturally and conventionally uh, categorized as poor prognosis, which is okay, but they tend to get lesser and lesser time as well. But the new trend is the contemporary trend is that such patients would probably need more emphasis and more time and more collaborative teamwork. There are things which obviously require more resources as well. I'm talking about in ideal circumstances, but since those circumstances may not be there, somehow that turns out to be not in the favor of the patient and family, because I think it's more of a logistic and operational resource issue rather than a clinical approach issue. So I think we need to continue to advocate and vouch for those patients. Um, for example, if some hospitals have a slow stream or different levels of or different tiers of care, I think it's a good opportunity, but that should not discount the time that is spent on them or the effort that is spent on them too. I think this is something we need to revisit. It is also a debatable issue, and I would really love to have opinions of my colleagues here who would like to comment on this, agree or disagree. Um, that would be interesting to have your input on this. Structural modification, single rooms, or some shared rooms. I think because we have seen the spectrum of shared room and single room, so we all, I think, have the same opinion that single room, let's say a hospital has a single room for isolation purposes, but sometimes they need it for other indications as well. So I think if we are moving towards some expansion projects or moving towards an institute, because I have come to know some of the brilliant rehab physicians are involved in developing new rehab inpatient services, or they're working on it. And I've seen some wonderful places in the last couple of months. And so the infrastructure itself really matters, which can do the patient impact the patient experience, be it stroke or be it spinal cord injury, right? So we are talking about stroke rehab. We're talking about some other things which are affecting the stroke rehab too, and that's generally applicable to all disease groups. All right, so this one is a master stroke, I would say. Is there a good reason? I would really like if there's only one thing that everybody can get from here today and we go on tomorrow and remember this last slide. I think it's one of the few last slides here. I will try to skip it quick. That is there a good reason for my patient to be in the bed, or why my patient is in the bed, right? Other than it's a patient preference to probably rest. But what is the clinical reason for a patient to be in the bed? I think everybody would have a very hard time to answer that, right? What is the clinical reason for a patient in a bed in a rehab hospital, or which the patient is admitted 24/7 in a rehabilitation setting? And sometimes patients, they don't know, yeah, why am I in the bed, right? It's because my rehab services are over. Yes, we have designed the rehab services in a way, or it requires, but the contemporary evidence is going to the intensity and frequency and repetition to a much more higher level. Patients can, especially in stroke, patients can do much more high level. They have the ability to do much more high level of intensity, frequency, and repetitions of rehab services as compared to the standard 3 hours a day, 5 days or 6 days a week that is locked by the Western health system, because I guess my personal opinion is probably it's coming out of the insurance and certain requirements, and that has really capped the potential. And that is why many of our colleague therapists, they take the lead and they provide double sessions or triple sessions sometimes, or they combine sessions as well to help out the patients. So generally, I think the whole point is that if possible, logistically, operationally, clinically, why not? So again, why our patient with stroke, and now everybody's thinking, why our patient with stroke is in bed always, and it would be hard to get an answer to that. And sometimes we do question, at least I do question, that is the hospital bed or the hospitals are designed in a way to comfort the patients in rehab, or they are causing more harm than comfort by just staying immobile in the bed in an inpatient unit 24/7 out of majority of the time, right? So this is we really, as rehab clinicians and rehab providers, we really need to advocate, um, just to be able to spend more time out of the bed as well. So approaching musculoskeletal disorders, this is everybody I think is a very famous slide that majority of the patients who do not, many of the patients who do not have any symptoms, they may have a radiological problem, a radiological evidence of disease where they are symptomless, right? So this is a very classic slide that when we are dealing with MSK problems, we encourage that, it's a subluxation in the shoulder is there. It's clinically evident. I mean, even if you do the X-ray, what difference would it make unless you're suspecting a dislocation or a Hill-Sachs collision and so on and so forth, right? Or a very hard tendinopathy that you're thinking maybe calcified, right? So the idea is not to emphasize in the rheology. So these are the frequencies of different impairments in stroke survivors. So this is a common, not a very uncommon presentation of post-stroke headaches, poorness neck. It could be poor neck posturing. It could be impingement. This is the patients are confined in ICU for a long period of time on an inappropriate mattress or a bed. They may have impingements or irritation or spasms of the upper musculature causing greater occipital nerve impingement. Craniotomy or craniotomy, you can see where the excisions are coming from, and those excisions can cause nerve damage for greater occipital nerve if they are cut along the way. And they may, or a tight helmet may itself cause this kind of unilateral headaches too. So it may not be headache coming from neurogenically from the brain matter itself. It would be coming from the neural nerve tissue outside. So we see this neck posturing is truly the neck which is tilted. Is it a PISA syndrome? Is it a Pusher syndrome? Right. So specific things about stroke: is the patient having a tilt of the neck because of the gaze preference, because of the dystonia, or is it visual spatial perceptual deficits? Right. So this is where our opinion as physician, OT's opinion, everybody's opinion, nursing opinion, speech and speech therapist, everybody's opinion come in, and you can decide as to how to treat the problem. Is it a neck problem, or is it a visual or visual spatial problem? Right. Then we have neck dystonias as well. Hemiplegic shoulder, CRPS, classically, sometimes it's a bit tricky. It is a bit tricky to differentiate early on in the CRPS versus edema. Now, the problem is that if we go with the Budapest criteria, probably it's a bit too late, right? If we're dealing with a subacute stroke, patients had a stroke and came to rehab, and we are trying to fill in the criteria of pseudomotor changism, probably it's a bit too late now. So this is the downside of the criterias. Let's say if you have seronegative arthropathies or you have any criterias, if we go with the fulfilling of the criterias, it's slightly a bit late, I guess. We need to pick it on early on, even if the patients do not fulfill the criteria. We need to be able to, and that obviously comes with with experience, with the help of colleagues, having input from other people, because post-stroke edema is not an uncommon entity as well. And sometimes post-stroke edema in the leg, patients with obesity, it may just look like a dependent edema, right? So, but the pain is out of proportion. We may not necessarily see the warmth, classic warmth as classic pseudomotor changes. Yes, Dr. Varun. Yeah, right hand stroke patients, sorry. So again, patients may not be able to express language impairment, aphasias. They may not be able to express the maximum tenderness. So that's where the examination matters the most. It's strangely not very uncommon. Patients with stroke usually do get this, trigger points and myofascial pain in the classic myofascial areas too, which could be a differential in hemiplegic shoulder pain. So, this is again all the structures which can be commonly involved, as you know, in hemiplegic shoulder pain. It could be the AC joint, it could be the bicipital tendinopathy, it could be subacromial pathology, it could be the glenohumeral joint pathology, or it could be the rotator cuff problem as well, right? So cannot emphasize on this enough. Positioning. I think that's one way of preventing worsening pain, worsening spasticity, right? Worsening or chronic hemodynamic changes as well. Yeah, so these are some of the guidelines there, right? So we don't want to do that with the pulley exercises, especially with subluxation. Support is a better option, but it's very hard to find a correct support. I would say correct shoulder support. I mean, the names go synonymously. Some, the both of them are sports, both of them are considered slings as well. But I'm just putting the names here just to, because if we need to keep the hand open for motor recovery, right? Yeah, so we are all familiar with the spastic limbs. Here, most important interventions would be mobilize as much as possible, position appropriately as much as possible. The word appropriate is there. Hip pain, likely I've seen because of the hemiparetic changes. The the body dynamics are disturbed. So somebody's knee pain, now they have hip pain on the opposite side. Most commonly, we have seen bursitis or tendinopathy as well. Yeah, this is not an uncommon scenario where the infrapatellar branch of the saphenous nerve may be involved, or peasants in bursa may be involved, because patients are prolonged spasticity, they're sitting most of the time, so their hamstrings as slightly, they have a bit of tendinopathy, which are sitting as at a part of the pes sensory too. Not uncommon with this SI joint problems, band-like problems. Patients do come across. I have band-like pain, long sitting, again, the mechanical changes that the patients are having. Yeah, one thing I just wanted to show that it's not always the joint itself. It's a heavily loaded, very solid joint. Majority of the joint is actually fibrous joint, and the synovial joint is only, as you know, is a small part. I'm not sure if you can see my mouse, is a small part on the lower part of the SI joint, right? Quadratus lumboris stream is also very important on the, so this diagram on the right side of the screen on the lower side, this is also a very common complaint of spasm of the quadratus lumborum. And piriformis, we have seen that from time to time. Clunial nerve entrapment is also something which we have seen, and our friends from interventional pain can share their experience on the clunial nerve blocks too. SI joint pain, as we all know, is tricky. So I would like to finish over here with the last slide of move as much as possible. Earlier, the better, more frequent, intense, and repetitive. Thank you very much. And I would go with any comments or questions.
Thank you so much, Dr. Ahmad, for this wonderful, enlightening lecture. Really touch our daily practice. Please, if anyone has any question, feel free to ask.
Dr. Jamila, I see some of the comments here. I would just go from yeah. So I think last one was from Dr. Shahad, and after that, Dr. Noura mentioned about stroke education. What are the practical points to deal with pitfalls and red flags in stroke rehab patients? And I'm not sure about the red flags. What if you can point out if you're talking about clinical or non-clinical? So inclusion, Dr. Nifin is asking about inclusion and exclusion criteria for patient admission. That has to be that is multifactorial. That depends upon, that's quite an institutional criteria, but generally, if you're moving towards accreditation processes and payment structure systems, you can decide about the minimum. I think the general trend is to be able to have, to be able to participate 3 hours of therapy sessions over 5 days or 6 days a week. and then you can, depending upon how your system or support services do you have, I think there is a leeway about the medical necessity or the clinical appropriateness for admissions. Because let's say, for example, for quite a long time, uh, at KFMC, when we were in the early phases, we had a lot of acute cases. So our naturally trend was, because we had a bulk of patients coming from acute care services, so almost 70% of the patients were from acute care. So from within KFMC, and the 30 were from outside. So we were not able to accommodate patients for really readmissions or chronic cases from time to time, with exceptions, right? So it depends upon your, your hospital resources, your logistics, your payment structures, and obviously your competencies in the of the team, and what is the comfort level as well, how much support systems you have in terms of, if you're at a tertiary care, you're not at a tertiary care, so these are the things which are important. In acute rehab, Dr. Ahmad is asking, in acute rehab, who's responsible for medication for stroke patient, or neurology or PM&R? There are different interpretations of acute rehab, and it depends upon which service line you are in, and what services you have at your hospital, right? So some of the hospitals, they have the rehab physicians, they are managing, obviously, as a physicians across all the medications, except for, let's say, restricted medications, or patients, for example, if anybody has UTI, some of the physicians feel comfortable starting the medications to, or respiration pneumonia, or even acute management of status epilepticus or sudden loss of consciousness. So, and then, different services can be, referred upon. So some of the hospitals, this is completely under internal medicine, let's say, right? And they are the ones who are looking after, as they say, as non-rehab, but it's again how you define it, right? So if you're talking about as a rehab physician for rehab scope of practice, right? So what are the scope of practice as physicians is medical management of patients with whatever background they have, and obviously consult services are there. So it depends, entirely depends upon how is the workload, how is the logistics, again, what is the background of the team. I think I've seen all the 3-4 different kind of variations here in Saudi Arabia, in Pakistan, and in the US as well. So all the systems exist. So there's no strict, criteria. But largely, the standards, the Western standards, would be to be able. The rehab physicians are generally expected to manage medications, and then the rest of the services are consult based. Also, do you believe that noise and discomfort sometimes acts as brain stimulators and somehow? I'm not sure. Like, obviously, we know that noise and discomfort are negative brain stimulators generally for patients with agitation, and sleep problems. Okay. So Dr. Jamal is asking, what about neuroplasticity in stroke patients? So see, everything is neuroplasticity. Whatever new we're learning is neuroplasticity. If I learn to play tennis today, that is neuroplasticity, right? If I, go to a new place and I'm trying to learn a new skill, that is neuroplasticity. So the whole process is basically neuroplasticity. So if you're asking about the 3 common principles of neuroplasticity in stroke, that would be frequency, intensity, and repetition. And that brings to the same thing which I was referring to, that we need to really, there's a lot of margin to optimize. I personally believe that generally patients around the world probably are underemphasized in terms of frequency, intensity, and repetition. So Dr. Khanim is asking about what is your opinion regarding acetylcholine inhibitors with language and cognitive impairment with acute stroke? Well, I don't have much experience on those lines. Usually we have seen neurology would be taking over, but if any one of the other colleagues would be happy to emphasize on this, it would be great. What practical advice would you give regarding post-stroke depression? I think PSD stands for post-stroke depression prophylactic with aggressive for if your question is regarding prophylactic treatment of post-stroke depression, I do not actually favor that. Also, at the same time, it's depending upon what scale are you using to assess the post-stroke depression. If you're using HADS or some other questionnaire for post-stroke depression, if the patient qualifies and you're suspecting based on clinical judgment or an objective tool, that's fine. But 1/3 of the patients, they may have aphasia, so we are working on Arabic version of the stroke aphasia depression rating scale. So it's an objective scale. It's a subjective tool where anybody who's observing the patients can actually fill up the tool to be able to justify the use of psychiatric medications, if that's what your question is. But typically for post-stroke depression, antidepressants would be 3 to 6 months. I personally favor 6 months as well if we try to justify some studies justify the use of fluoxetine for motor recovery and also stimulant effect too. All right, so I think children, which type of exercises can be used in children? I think I would leave that for somebody with a pediatric experience. Yeah. So yeah, so these are the questions here, Dr. Jamil. If there's anybody else would like to ask or comment verbally, we still have 8 minutes. Yeah.
I think no more question, Dr. Ahmad.
Which one is?
I think that's all for today. No more question there in the
Oh,
chat.
no more question. Okay.
But I have just one question. I'm not sure if what's your experience with patients with the locked-in syndrome? Usually, how we approach this patient from rehab perspective? Is it just family education, caregiver education, and equipment, or there is anything we can do for them?
That's one area where I think assisted technology can do wonders. I used to have a young patient with partial locked-in syndrome. Two patients actually, one was partial and one was complete locked-in syndrome. And she had her rehab at Germany, and the kind of technology she brought back, started making me thinking about, how theoretically what we have read about the emphasis on the assistive technology can really impact patient's life. She only had like one plane of eye movements and blinking, and she was writing emails and writing books. And I think she was a medical student or somehow related to medical field at her undergraduate. I think a lot of counseling and training, counseling on the family members, and I personally believe from a clinical perspective, assistive technology is the way to go. We should not probably, as I said earlier, that the immobile patient and the chronic patients and then not so moving patient gets the least attention. I think it's time to flip that pyramid, and we need to probably we need to be spending more time with such cases because they can certainly surprise us. Yeah.
Yes, I see. Okay. Thank you so much, Dr. Ahmed. I'm so grateful for accepting our invitation and sharing your experience with us today.
Thank you for having me.
Okay, we can conclude. Stay safe all and have a good night. And see you again tomorrow, inshallah.
Right.
جزاكم الله خير, Dr. Ahmed. And hopefully we'll see you.
Inshallah. Thank you very much.
Thank you so much.
Yeah.
Goodbye. Assalamu alaikum.